Good evening, everyone. Hi. Thanks for coming out today to learn about gynecologic cancers. I think more people are going to come in, so they'll keep filling in. But my name is Ruchi Garg. I'm a gynecologic oncologist. I'll sort of tell you a little bit more about myself and what we do. But today we're going to talk about gynecologic cancers. We're going to talk about the common signs, symptoms, and sort of very broad stroke treatments. This is really sort of just to get people to sort of know about gynecologic cancers, essentially. So who are gynecologic oncologists? Oh, there's also a live stream going on, so that's the whole reason I'm holding this, apparently. So who are gynecologic oncologists? We are physicians who specialize in the treatment of gynecologic cancers. So we call them below-the-belt cancers, basically. So we're the only surgical oncology specialty that is trained to do our own chemotherapy as well. So we follow our patients basically from the beginning to the end, essentially. We do, complex oncologic surgery where we are trained to not just take out the pelvic organs, but we also do bowel surgery. At bigger centers, some of us do, partial liver sections. We'll do, go up to the chest cavity as well. So there's a whole extensive wide range of surgeries that we're actually trained to do, not necessarily do an active role every day, especially at community centers, but definitely at major centers we do. We treat ovarian cancers, uterine cancers, vulvar cancers, vaginal cancers, fallopian tube cancers, cervical cancers. And then there's other sort of cancers that you may not have heard about. They're called gestational trophoblastic tumors or sarcomas of the female reproductive organs. It's been shown that women who are actually treated for their GYN cancers by gynecologic oncologists have twice the survival rate, than women who are not. Not working? Sure. I talk with my hands, so this is very. So the training for a GYN oncologist can be anywhere from 14 to 16 years. After our basic undergraduate, I did my undergraduate in 2 years, but anywhere from 2 to 4 years, and you go on to do medical school for 4 years. Then we are actually fully trained OBGYNs, actually, so I've delivered about 1,000 kids, but that was it. And so that was 4 years of residency training, and then if we choose to do the subspecialty training, which is called fellowship. So I did my medical school at University of Miami, then did my residency at Johns Hopkins in Baltimore, and then went up to Seattle, University of Washington for my fellowship. So that was 4 years as well. So 14 years later, I'm here. And that was 8 years ago, so I can't believe it's been that long now. Hi, come on in. That's okay. So we just sort of started talking about gynecologic cancers. This is sort of the anatomy. Can you guys see the screen? Do I need to turn the light down? No. So this is the anatomy. This is every patient of mine who gets a consult with me will get this anatomy lecture, essentially, before, as we get started, just to sort of orient you to what we have. So we have the lining of the uterus is called the endometrium, A lot of times the endometrium or endometrial cancer and uterine cancer words are used interchangeably. But if we are saying endometrial cancer, we know as physicians that the cancer started in the lining of the uterus, because uterine cancers can incorporate the more larger spectrum where the cancer may have started in the muscle wall, and those are called the sarcomas. So here's the uterus. We have the tubes, the fallopian tubes, the ovaries. They're all attached to each other in one way or the other. And then we have the cervix, which is the lower part of the uterus. Okay, so uterus and cervix are one organ. Okay, so if you're sort of describing the body, face is part of the body. Similarly, uterus is cervix is part of the uterus, and then the vagina is the canal, and then external portion, the outer perineal area, external portion is all vulva. In 2017, the estimated incidence of these cancers. So we're going to compare this to breast cancer. We hear about breast cancer all the time. Our Society of Gynecologic Oncologists, has really sort of tried to emphasize GYN cancers as well, because they are the cancers that sort of get missed, okay, and part of it amongst the females, and part of it is because there's so much breast cancer. Not to, put that down in any way, but so breast cancer, there's the incidence is about 255,000 breast cancers per year. About 2,500 of those are actually in males. Okay, there's male breast cancer as well. Majority of those are associated with genetic association, hereditary issues, but about 250,000 are from amongst females, and about 41,000 of those patients pass away from this every year. In comparison, the cancers of the genital system, are about 280,000, but that includes cervix cancer, uterine cancer, ovarian cancer, vulvar cancer, vaginal cancer, and prostate cancer. So if you actually cut out prostate cancer, which is 161,000 of those, so we're talking about 120,000 cases of gynecologic cancers per year. The problem is, out of those 120,000, about 30,000 patients die from their GYN cancers. Okay, so that's 25%. Okay, in comparison, if you go back to the breast cancer, it's 240,000 out of 250,000. So that's why we're emphasizing GYN cancers, because some of the cancers, when they're diagnosed, they're diagnosed at too advanced of stages, and the death rate is escalated as a result. It's hard to read, and that's why I sort of highlighted a little bit. This is taken from American Cancer Society website. And again, sort of just showing that in another perspective, the incidence of, so amongst the females, the uterine cancer has the fourth highest incidence. And you can see that ovarian cancer doesn't make it to the list on there. I'd say about 5 years ago, it was number 10 on that list. But then if you look at the estimated deaths, ovarian cancer is number 5 and uterine cancer is number 6. Okay, so on the list they come up, and that's exactly what I just sort of emphasized, that they're diagnosed a little bit late in the games, and we lose out on the death aspect from that. So we're going to start by talking about cervical cancer. So cervical cancer, you can see, sort of go down the screen, there's normal cervix, okay? Then the second picture depicts sort of the early beginnings of the cancer. And, a lot of times patients actually ask me when I'm operating, oh, can you see the cancer? And yes, we can. Actually, cancer cells are our own cells that have gone haywire. So they actually look like, abnormal growth. Okay, so we can tell, we can visualize. For the most part, we can visualize the cancer cells. So, so there's early stage 1B, late stage 1B, and then this is stage 2, where the cancer has sort of spread beyond the cervix into the vagina and sort of the surrounding tissue of the cervix. What are the signs and symptoms of cervical cancer? Bleeding after intercourse is one of the most common signs that patients encounter. Occasional spotting here and there, that's different. But if you're bleeding every time after intercourse and noticing a good bloody show, that is a reason for concern. It's not something that should be ignored. Excessive persistent discharge is another reason, because those tumor cells, as they're shedding, sometimes they can produce a lot more secretions. It can also be because majority of cervical cancers actually start due to a virus called HPV, and that virus can cause a lot of mucosal changes that can cause the secretions to increase as well. There could be abnormal bleeding in between periods, so it won't be associated with heavy menstrual cycles, but it can be associated with irregular spotting in between. Or the patients can have no symptoms, okay, where the only time they're getting picked up as cervical cancer patients is through abnormal pap smears, and so that's why we emphasize screening, okay. The risk factors, one of the risk factors, the major risk factor that I talked about is HPV. 99.6% of cervical cancer patients will have had HPV at some point. It's stemming from HPV. Even if HPV is not detected at the time of the cancer diagnosis, HPV is the leading cause, in over 99% of the cases. The smoking is another risk factor. So smoking actually decreases the immune system, our body's immune system, and especially locally, it allows the HPV virus to be persistent for a longer time in patients' bodies, and that allows the HPV virus to cause more cellular changes, and that can cause the cells to progress to cancer, essentially. It still boggles me when I would have had patients who are like chronic smokers, and they'll come to me after having had abnormal pap smears for years, and they're sent to me for a consult, and I was like, well, the first question is, has anybody, why haven't you stopped smoking, and they are just completely unaware. They haven't been told, and a lot of times I think part of it is it's our a little bit of a stigma where, sometimes as doctors, we feel uncomfortable about telling patients that, okay, you need to stop smoking because it's so common, but yeah, that's part of it, that, smoking needs to be stopped. Weakened immune system. So aside from what smoking does and nicotine does, the weakened immune system is actually associated with transplant patients, for example, or with patients who have HIV or something like that. Those patients actually have a lot more of these abnormal PAPs and faster progression to cervical cancers. Sexual activity at a young age. So again, HPV is contracted sexually. Over 90 to 95% people who are sexually active will have HPV at some point in their life. Okay, so when I get patients, they always will ask me, well, is this something that I did, or is it something that my husband or my partner is doing? And I always sort of tell them it could just take one sexual encounter, and HPV can be passed on. So sexual activity at a younger age, the younger patients actually have more exposed at-risk cervical tissue, and so HPV can stick on more at that time, and that can cause cells to change more at that time. And then failure to get pap tests. It's been shown, yes, go ahead. Well, so, it's not, so I don't know how to answer that question. That's a very sort of, it's a very societal, cultural thing, basically. I'll tell you, like in Eastern cultures where marriages are done, or, happen early, or, and there are more kids, early on, those patients end up having higher rates of precancer and cancer lesions, cervical cancer lesions. And so there isn't a cutoff for age, per se, in that sense, but it, I mean, for a person who starts being sexually active at 21 is going to have less risk than a person who started being sexually active at 15, essentially. So that's how it's been compared. It's been compared by group, essentially, like that, but it hasn't, there's not a number that, okay, after 18, you're less at risk. That's not the case, So, and then failure to get pap tests, it's actually, we see this very commonly in this day and age, and especially now, and I'll get to that part, but where the patients have actually not had a pap test for like 5 years, okay? And a lot of times, most of these patients who we are picking up with advanced cervical cancer now in this day and age is because patients have not had pap smears for about 5 to 7 years, okay? Until what age? So the guidelines say until age 70, okay, that you need to have pap smears, and you start having them at age 21. The only thing is that the guidelines also say that when you're younger, you can actually space out the pap smears to every like 2 years, and then after you're 30, you can even space them out further based on your risk factors, okay? So anywhere from 3 to 5 years. I have a problem with that guideline, and the reason is because in 3 to 5 years, it's very easy for that 5 years to become 7 years because you sort of lose track of when, well, I just went, or something like that. So it's, and it's not, the guidelines don't sort of tell that, okay, even if you don't get your pap smear, doesn't mean you don't go to your doctor for a checkup, okay? And many women end up just using their OBGYNs as their primary cares, and then they don't end up coming. Yeah, go ahead. So after partial hysterectomy, so it depends on what, and I'm going to talk about what partial hysterectomy definition is. I'm assuming what you're saying with partial hysterectomy is that you have your ovaries still, but you've had your uterus and cervix removed. If you never had abnormal pap smears in the past, and you've had 3 normal pap smears within the last 10 years, then you don't need to have pap smears anymore. Yeah. So screening and prevention, pap smear, okay? Pap smear was, I believe, discovered like in 1950s, 1960s, and it changed, the cervical cancer world, especially in developed countries. The rates of cancer went down significantly. We are able to detect precancerous lesions, so we sort of, that's the whole point of screening, that you actually prevent the cancer from becoming cancer. And then the other thing that got added in the last decade and a half is HPV testing. We used to do reflex HPV testing, meaning that if there was an abnormality on the pap smear, then they tested for HPV. Well, it's been shown that sometimes we don't pick up the abnormality in the pap smear, but if we pick up the HPV virus, then it can sort of be a red flag that this patient needs a little bit more closer monitoring for the time being, okay? And then we have prophylactic HPV vaccines that got approved in 2006. It's the first time, and it's probably going to be the only time that in our lifetime that we have vaccines that prevent cancer, okay? And the success rate of these vaccines is so significant that, for medical community, for us, it's so hard to fathom when people are not getting the vaccines, okay? So the HPV vaccines are recommended for males and females aged 9 through 26, okay? And the latest HPV vaccine, it used to be HPV vaccine with there are actually hundreds of types of HPVs, and there are about 50 that cause cancers. And one of the initial 2 HPV vaccines were one with 2 of the types that were associated with 70% of the cancers. And then another one had the 4 types, which were, so 2 were associated with the 70% cancers, and then 2 low risk types, which were associated with 90% of genital warts. So HPV also can cause genital warts. So those vaccines were efficacious against that. And now there's a latest HPV vaccine that is against 9 HPV types. So it's efficacious against over 90% of the cancers.
Can you recommend a new vaccine for a person that owed 2 shots? The first vaccine was 20 years ago. Because now the composition is different. Would they allow a third shot vaccination?
So they're not saying that right now. The guidelines say that don't switch them over. So if a person started the first type, they want you to continue doing the same ones, and finish the whole series in that manner. Because if you just get one vaccine, like for example, you've done the 2 of the old type and you get the 1 of the new type, yes, you'll mount enough response to those 4 types that were in the old type, but you won't mount enough response to the new ones without getting the rest of the vaccine series. So Pap test, why do we recommend, a screening test like yearly or, every couple of years or every 3 years? It's because the sensitivity of a screening test is not 100%. We don't detect 100% of the cancers with a Pap test on the first time, at the first test. So the sensitivity of a Pap test is only about 51%, okay? And so when we, as you can see, my little math down there, that, so if I detect 51% of abnormalities the first year. You come back the next year, I'm detecting 51% of the remaining 49%. So my sensitivity now has increased up to 76%. So now I'm, picking up 76% of the patients with abnormalities. And then the next year, that goes up to 88%. So that is why the follow-up and the frequent screening is necessary, okay? And then the co-testing increases my sensitivity, from 50 some odd percent to as high as 80 to almost 100% at times. Okay. And co-testing is basically, so what we are doing now is patients who are over age 30, the guidelines say that, so even if you have a normal Pap smear, we have to test HPV, and that's called co-testing. And you have to actually ask for that to your doctors, because not every doctor has switched over to that, okay? And there's still, because there's a special place to mark on the lab sheet, and many doctors were used to just marking the reflex testing, which is if the Pap smear is abnormal, then the HPV will be tested. But if you actually say co-test the patient, then they will test the HPV. So it has to be, it's worth a question. No, on the Pap smears, no. Yeah. So, we sort of went over a little bit more about the vaccines. Vaccines are, as I said, can prevent 70% of the 70% of the cancers. Okay, so the HPV 16 and 18 are the 2 big ones that are in the vaccine and actually cause 70% of the cancers, and they were efficacious. The vaccine efficacy was 90 to 95%, so they were pretty significant, especially if they're given in the prophylactic setting. And what that means is that the patient hasn't been exposed yet. So that is why the age of the vaccination is so young, because we want the patient to be getting the vaccine before they're sexually active. Okay, and there was a lot of negativity against this HPV vaccine initially, that we're giving permission to our kids to be sexually active. I mean, who are we fooling, right? I mean, not only that, I mean, at some point, people, they will be sexually active. Not only that, the hepatitis B vaccine, which was like a mandatory, which became a mandatory vaccine for all the schools. How do people get hepatitis B? That used to be sort of my, that always like sort of befuddled me, because hepatitis B is contracted by sexual activity or by, exchange of needles, similar to hepatitis C. So, I mean, how can, it just did, it just sort of was showed to us that people really didn't understand, what was happening. So the other good part about the vaccines is that it can actually also prevent vulvar cancers and vaginal cancers and precancer lesions, because the same HPV can affect the vagina and the vulva. Okay, so there's that side benefit from that too. Standard treatment. So we can actually treat cervical cancer very early stage, the earliest stage 1A1, by doing what's called cold knife cone, which is a very smaller surgery, just localized resection of the cancer, and we can cure many patients like that. And most of the time we get those that early stage cancer in younger patients who haven't had kids yet. So we want to be able to do conservative surgery in them so that they are able to maintain their fertility. If the cancer is more advanced in stage, but it's still localized, then we can do what's called radical hysterectomy. And what radical hysterectomy entails is we take tissue, not just, so cervix is the main primary source of the cancer, but we take surrounding tissue. So we take a little bit of upper vagina, and we take what's called perimetria, which is the surrounding tissue next to the cervix that's at risk. And that all is taken sort of en bloc all together, essentially, to resect the cancer and get margins, and hopefully not need any radiation or any other treatment subsequently. That radical hysterectomy is a very specialized surgery, and that's essentially one of the sort of hallmarks of GYN oncologists, because our specialty is the only specialty that's trained to do that. Okay. If the cancer has become more advanced, then the patients need to be treated with chemotherapy and radiation, or if it's still sort of advanced locally, then they can be treated with chemotherapy and radiation. But if it's sort of advanced systemically, then they primarily need chemotherapy. And chemotherapy is given intravenously, so it can sort of go through all the body's cells, and that way, that's how it affects the more distant disease. Some of the new surgical things for treatment of cervical cancer is something called radical trachelectomy. So if I still get a younger patient who still wants fertility and has cervical cancer that is amenable to surgery, okay, then I can actually offer them a surgery called radical trachelectomy, where I am actually just taking the cervix out along with that perimetrial tissue and the upper vagina, the at risk, and putting a permanent stitch at the lower end of the uterus and reattaching the uterus to the vagina. And the patients can actually carry their own child still. It was really sort of mastered in France and Canada, and now it's sort of a commonly offered procedure by us, and with good success. And then the other factor, the other new direction is sentinel lymph node testing, which is very commonly done in breast cancer. We really sort of learned from them. Sentinel lymph nodes is basically, so part of cancer staging includes taking out lymph nodes as well, and a lot of times lymph nodes can cause a lot of swelling in the lower extremities. Like if you've sort of known any breast cancer patient, if they've had axillary lymph node dissection, they have arm swelling. So similarly, gynecologic patients can have lower extremity swelling. And by doing sentinel lymph nodes, what we're doing is we're injecting a dye in the primary cancer at the cervix, and we are seeing where that organ, that area actually traces down to, which are the first nodes that it traces down to, and that first node is called the sentinel node. So we know that because nodes sort of follow that pattern, they have so if I take out that node and if it's negative for cancer, then I don't need to do full nodal dissection and subject that patient to that risk of swelling, the lymphedema. Surgical approaches, until recently, everything was done in an open abdominal manner, and that could be vertical incision or a horizontal bikini cut incision. Most of our incisions are open vertical incisions because that gives us the best exposure. and it gives us access to the upper abdomen. But all of that has really changed in the last 15 to 20 years. Things have changed to laparoscopic, minimally invasive camera surgeries. In the last 10 years, robotics has come on board, which is another technology to do laparoscopic surgery. So I'm a robotic surgeon. Robotics was approved in 2005 by FDA for GYN surgeries. I was trained in 2006, and really it sort of changed how we do surgery. I mean, I have 3D visualization, so I basically put the ports, the instruments into the patient, and I attach that to the robotic arms, basically, and then I'm sitting down at a console. It basically looks like a video game station, and I am moving the robotic arms from there. Robot can't move by itself. I have to move it. I'm looking in a 3D console, and I'm moving those arms. I have a 540-degree motion, to my wrist. And I have 25x magnification. So it's all of us who do robotic surgery, we say it's made us better open surgeons because we can see tissue that we couldn't see when we were doing open surgery underneath, and it's made us a better surgeon in that manner. My patients are going home after robotic hysterectomies on the same day. 90% of my patients go home within 6 hours after these surgeries now. So uterine cancer, we're going to shift to the next cancer, okay? So all, sort of general overview of like how we stage cancers. Most of our cancers are actually staged surgically, okay? Because it's always the first question that patients ask me, when they have a biopsy-proven cancer. Oh, what stage is it? And I can't tell them that because until I go into surgery and take the tissue and the pathology, I can't tell them the true stage of their cancer. Did you have a question? No. Okay. So most of the time, stage 1 is always sort of limited to the organ itself. Stage 2 is like spreading to this little bit to the surrounding tissue. Stage 3 is spread to the upper abdomen, and then stage 4 is spread to, could be anywhere else essentially, okay? Or if it's going into the upper abdomen, then it's going deeper into the organs, essentially. Signs and symptoms, again, for uterine cancer as well, abnormal vaginal bleeding. I know I sort of, said that in cervical cancer, but I mean, as I said, they're both same organ, and that is one of the biggest telltale for something being abnormal. Just because you have abnormal vaginal bleeding doesn't mean you have cancer, but it's a red flag that should be checked out, essentially. So bleeding in between periods, irregular or heavy bleeding, and any kind of postmenopausal bleeding or spotting, okay? I have so many uterine cancer patients who will, they're in their 60s and they're like, I had spotting about a year ago, and then that's it. It never happened again, and I never really sort of bothered again. And then it happened again now, so I figured, let me go ahead and go to the doctor. And yes, of course, they get diagnosed with, they get sent to me for uterine cancer. Any kind of postmenopausal spotting or bleeding needs to be checked out, okay? 20% times there's going to be an abnormality there, okay? What was that? Okay. Any kind of pelvic pain or pressure that's persistent in nature, okay? So, occasional twinges here and there, that's normal life. But something, if you sort of think about your last few weeks and you're like, I've had this pain every single day. I felt this pressure every single day. It's a red flag, okay? Body's not meant to do that. So why it concerns us in our field is that that may be a sign of more advanced cancer. Uterine cancer doesn't, majority of times presents in stage 1, and at that time we don't have pain and pressure symptoms, but if it's more advanced, patients will present with that. Pelvic pain and pressure.
Is that like right after your period? Is that right before? Or just
Anytime, that's persistent, yeah. For like, if you're sort of noticing it for several days in a, couple of weeks, 2 or 3 weeks in a row, every day, then that's something of concern. Mm-hmm.
And
bloody discharge. Yeah. You know, people have different thresholds for pain. Were you going to say something to me?
I was just asking her to repeat the question.
Oh, sorry.
About spotting.
The question that was asked was, how do you, is it spotting or is it just discharge? So it's actually bloody spotting or bloody discharge. That so. How do you differentiate between pain and pressure? You know, it's basically you have to sort of be aware of your body essentially. You know, that if you're noticing some heaviness or, you know, some bladder pressure constantly every single day, or you're feeling some sort of low back achiness or pain or heaviness, you know, for several days in a row, you know, for weeks in a row, that, you know, doesn't necessarily have to be pain, you know, throbbing pain. So yeah, different than bloating, but yeah, I mean, same thing. If you're having persistent bloating for several weeks, you know, and you sort of think about your last couple months and you're like, you know, I can't really remember a day that I wasn't bloated. Yeah, that's a reason for concern. Okay.
But that pain and pressure not necessarily means.
None of this necessarily means that you have cancer. As I said, remember, the rate of cancers are actually very low. So more than likely you don't have the cancer, but it's a good red flag to come in to be checked out. So the way we diagnose uterine cancer is by doing either an office endometrial biopsy, where we actually stick a pipette, like a long tube, inside the uterus and actually take some scrapings, some cells from there. Or we can do this in the operating room, which is called dilation and curettage, where we take a bigger sample. The gold standard is dilation and curettage. It picks up about 94 to 95% of the cancers. The office endometrial biopsy picks up 90% of the cancers. So we tend to try, you know, to do that first so that we can avoid another visit to the operating room, you know, for the patient. But sometimes we just are not able to. We're just not successful in getting a good biopsy in the office or something. Then we have to take them to the operating room, or the patient just can't tolerate it. Risk factors: unopposed estrogen. Okay, this is one of my sort of pet peeves when patients sort of come to me and they have been on either sort of biologic estrogens, like they, you know, that it's I'm on natural estrogen. Okay, so that shouldn't harm me, or the patients have been started. You know, and a lot of times, unfortunately, it is through the physicians that they have been started on estrogen treatment, but they actually have their uterus and they haven't been given something to counteract the effect of the estrogen on the lining of the uterus, and so then they develop cancer from that. Estrogen itself affects the lining of the uterus, and it can cause the precancerous and the cancerous growths. Similarly, I think I sort of heard you say tamoxifen. Somebody said tamoxifen. Tamoxifen, which is used very commonly for post-breast cancer treatment, it acts like an anti-estrogen medication in breast and ovarian tissue, but it acts as pro-estrogenic medication in lining of the uterus. So it actually increases the risk of uterine cancer by 2.5 times.
What about an aromatase inhibitor?
That doesn't. Yeah, works in a different manner. Obesity. So obesity sort of links back to the estrogen, actually. So higher levels of obesity or higher BMI increases the estrogen level in our body, because then there's higher conversion of to estrogen in our peripheral adipose tissue, in our fatty tissue. Okay, so when I was looking at those ACS numbers, the American Cancer Society numbers, the number of uterine cancer, the incidence of uterine cancer actually increased, and I believe part of it is because our society at large is becoming more obese. I have so many young patients. So on average, uterine cancer is diagnosed, or endometrial cancer is diagnosed in 50s to 60s. I have so many uterine cancer patients who are in their 30s. And part of this reason is because they have been obese all their life, you know, childhood obesity, and that's what's led to their cancer. diabetes. So diabetes, again, is linked to obesity and can increase the risk of uterine cancer, hypertension. So all of these are sort of comorbidities that are somehow linked to each other, with obesity and higher estrogen level, essentially. Late menopause is also, this is sort of a textbook answer as to what are the risk factors. Okay, late menopause, and essentially, again, that's a longer exposure to estrogen from your body. So menopause is basically when your ovaries are decreasing or stopping to produce estrogen. Okay, so if you have late menopause, meaning your ovaries are taking longer in your body to go through that change of life, then you're exposed to estrogen for a longer time and so that increases your risk. Okay, so average age of menopause is 51. So if you're still sort of menstruating and haven't become menopausal until age like 55, 60, then that's a risk factor essentially. And then genetics plays a role in uterine cancer. About 5 to 10% of patients with uterine cancer have the cancer because of hereditary reasons. Okay. Screening and prevention. Well, I think I've beaten this topic down, that you need to follow up on abnormal bleeding. Any kind of bleeding that's abnormal needs to be followed up on. Then diet and exercise. I really emphasize that on my uterine cancer patients. It's actually been shown that the recurrence of the cancer can be significantly decreased if you have the cancer, we've treated it, but now if you actually cut down on your BMI, you decrease the weight, then you will decrease the chances that the cancer will come back. Okay, so again, just like smoking, that's part of our job, of telling our patients to monitor their diets. Progesterone. So what I was talking about, estrogen alone, like unopposed estrogen, when you're taking estrogen hormone for replacement. If you have a uterus, you need to be on progesterone as well. So progesterone is the medication that actually counteracts the effect of estrogen on the uterus. The problem is that the estrogen and progesterone combination actually increases your risk of breast cancer. So, but I would take that risk over this because you have more screening for breast cancer, and majority of the breast cancers are actually picked up much earlier. So yeah, unopposed, taking estrogen by itself is a definite no-no if you have the uterus intact. And then in patients who are at risk due to hereditary reasons, we do prophylactic surgery on them. So with that HNPCC or Lynch syndrome, patients have about 40 to 60% risk of getting uterine cancer. So we actually do their surgeries by age 40, 45. We take their uterus out to prevent the cancers. Standard treatment, we can actually use progesterone to treat the cancer itself. So in my 30-year-olds who haven't had kids, I do use progesterone to, and there are certain criteria. It has to be sort of, the cells cannot look there's different shades of cancer, so they can't look too shady, essentially. It's called grade 1, grade 2, grade 3. So grade 1 is, that's how they have to be. They can't be grade 2 or grade 3. And then the cancer on scans cannot be sort of deeply invading, and then we can actually treat those patients with progesterone, so in a more conservative manner. We can also do progesterone through IUD, which is an intrauterine device which we can place inside their uterus, then they don't have to actually take pills every day for that. Surgery, we do robotic surgeries, minimally invasive surgeries for these patients. Endometrial cancer, that's become a standard. And it's been shown that that does not compromise their prognosis and survival. And, I've done these robotic surgeries on patients who are 450 pounds plus, and I'm able to do them, and, I'm vertically challenged. And the reason I can do that is because I can place those ports and then I can actually sit at somewhere else, and I'm not sort of leaning over on top of the patient. So the treatment also includes radiation therapy for patients, and that's on, again, based on the final pathology. If the cancer is too deeply invasive or there are other risk factors that increase their chance of the cancer coming back, then we actually give them radiation postoperatively. There used to be, about 20 years ago, we used to give them preoperative radiation, and we've sort of walked away from that. And then chemotherapy is given in about 5 to 10% of the patients, and that's usually if there's more advanced cancer or if the lymph nodes are positive and found at the time of the surgery. I have clinical trials as part of the treatment for every patient, and there aren't too many sort of upfront clinical trials for these for most of our GYN cancer patients, because there's a lot of sort of standard set first upfront treatments, but whenever the cancer recurs, if the cancer recurs, we don't have very good treatments, and that's when clinical trials are very, very important. So I was talking about hysterectomy earlier. I really sort of like to go over this every single time because the patients always say, I've had a partial hysterectomy. Well, in my mind, as a physician, the partial hysterectomy means supracervical hysterectomy, meaning your cervix has been left behind. Because as I said, uterus and cervix are one organ. Tubes are separate organ, ovaries are separate organ. Okay, so when I say that I'm going to do a hysterectomy, all I'm saying is uterus and cervix. But if I intend to take the tubes and the ovaries, I'm going to say total hysterectomy with bilateral salpingo oophorectomy. Okay, and that tells me, so bilateral is both, salpingo are the tubes, and oophorectomy ovaries. Okay, so I'm designating each organ has its name, and so very commonly, and even physicians say this too because it's sort of just become conventional, like partial hysterectomy. And at this time now, we sort of go with it and we say, okay, you've had your uterus removed, but you have your ovaries still. But it always needs to be confirmed. So as I had said, total hysterectomy is uterus and cervix. Supracervical hysterectomy or partial hysterectomy is leaving the cervix behind. Or total hysterectomy with tubes and ovaries, and then radical hysterectomy, as I had described before, taking the surrounding tissue. Leaving the cervix behind was more common in the, probably about 5 to 10 years ago, and it's probably still more common amongst non-oncologists. And initially the thought process was that the cervix helps with sexual function and it helps with pelvic support, and all of that has been proven to be incorrect in research, so we don't support that. So essentially, if you come to an oncologist, you pretty much are going to get a total hysterectomy. We're not going to counsel you for a supracervical hysterectomy. There's really no reason for it. It actually makes the surgery a little bit more challenging. Surgical new directions. Again, even in uterine cancer, the latest is actually sentinel lymph nodes, probably within the last 5 years, essentially. So early that our centers are just starting to do them. Again, we are trying to not do a full lymph node dissection as part of the staging. We're actually just putting the dye in and getting the the sentinel lymph node. And we're doing that mostly for grade 1, the less shady cancers, than the higher grades, because we know that those can really have as high as 30% risk of involvement of lymph nodes. And it's also being, again, questioned whether we actually truly need lymph nodes done in those really early cancers. So all of that is sort of, the jury's still out. Some people are doing it based on, certain risk factors, and some people are not. Okay, ovarian cancer. Ovarian cancer, I'm sort of, this is sort of, this data I've already sort of gone over, where I showed that the incidence of ovarian cancer wasn't as much. There's about 22,000 ovarian cancer incidences per year, but 14,000 deaths per year. So the ratio is really high, and the reason for that is because we don't pick up ovarian cancer. 70 to 80% of ovarian cancers are picked up at advanced stage 3 or 4. Okay, so again, I talked about staging, that stage 1 is limited to the ovaries, stage 2 is surrounding tissue, 3 is in the abdomen, 4 is further out. Mm-hmm. Yes.
You can still get ovarian cancer.
Yes.
Can you test for it with HPV?
No. So HPV is specific. So the question was, can you test for ovarian? So if you've had a hysterectomy and you still have your ovaries, can you test for ovarian cancer through HPV? So the answer is no. The HPV is more specific for cervical and vaginal. It's a local virus. It does not affect the ovaries and further on into the uterus even. There's no good screening test for ovarian cancer, and I'm going to go over that as well. But by having had a hysterectomy, you actually decrease your risk of ovarian cancer by 50%. Because we do think that despite the normal sort of risk factors, which I'll go over, we do think that there might be some environmental effects as well. And the access of the ovaries to the environment is through the uterus and the canal, and then connection through the tubes. Okay, so if we cut off that connection, then we decrease the risk, and it's been shown that we decrease the risk by 50%. The incidence, so even though, 22, what does that 22,000 women translate to? For a lifetime risk, and lifetime is defined by age 70, don't ask why, but lifetime risk is 1.3 to 1.7%, okay? Only in comparison to breast cancer, which is 12%, okay? So, if you've had a hysterectomy, you've decreased that 1.5% risk down to 0.75%. So it's a very low risk, okay? And that's one of the reasons we don't pick it up that much, because the incidence overall is so low. So 75% of patients are diagnosed at advanced stage, as we talked about, and the problem, so even though they're at advanced stage, we do good surgery for them, and about 70 to 80% of them, we can actually put in remission. Okay, so we have good chemotherapy up front, and we can put them in remission. Unfortunately, out of that, 70% will have recurrence. So it's a very aggressive cancer. We just don't win the battle that easily, and majority of the patients will have a recurrence.
The data of the 70% recurrence, this is before the new biotherapy.
It is. So, all of these data, all of these incidences and everything is all before, we've made a lot of strides recently in, as you know very well, the field, that I feel that we're going to see the impact of that in the few years to come. I actually noticed that even the incidence of ovarian cancer a couple years ago when I gave the lecture was about 23.5 or 24,000. Now it's 22,000. And I think that impact, that decrease in incidence is probably because of more knowledge about genetics. So genetic mutations for ovarian cancer actually sort of became, we gained more knowledge in the last 15 to 20 years. And we started doing prophylactic surgery, so we started decreasing the incidence of ovarian cancer, and now we're seeing that impact for sure. So signs and symptoms, it used to be called that the ovarian cancer is a silent killer. It's actually not true. All those symptoms that I was talking about, a lot of women, they sort of ignore those symptoms because we're so used to feeling bloaty every month. We're so used to having those vague symptoms. But the key to that is that you have those vague symptoms persistently for 2 or 3 weeks at a time. If you remember, you think of your last couple of months, a few months, you can't. Most of the time you felt that way. That's a bad sign. Okay. That's the time to not ignore it. So bloating, pelvic abdominal pain, pressure, urinary frequency. Okay, so if you feel, again, it's that pressure of the mass, the secretion from the ovarian tissue can also get you to feel that way. And then difficulty eating and early satiety. So feeling full early. Okay, again, if you're sort of feeling those symptoms for several weeks on at a time, then that's a reason to check out. It's been shown that even though those sound like advanced stage symptoms, even women who were early stage ovarian cancer patients had this conglomeration of symptoms for weeks ahead of time. So we can pick these up in early stage. It's just you have to be in tune to that aspect. There's not a number as to like how, it's just you feel like you're having to go to the restroom a lot more. I mean, it's not necessarily like, okay, I drink this water and I have to go in about half an hour, but I drink this water and I go like every 5 minutes, I mean, I feel it's not like there's not a number in that sense, but you feel doesn't feel normal, and it's a change for you. And that's one of the things that you have to notice, that it's a change for your own body's normal, okay? Risk factors, age, okay? De facto, as I had said, that cancer comes from our own cells, okay? So our body has very good checkpoint mechanism. We have checks and balances for the cells to not go crazy, to not grow out of control. Or cancer cells are basically that there was a problem in one of those checks and balances, and a cell started growing out of control, essentially. Well, as we get older, we hear about more cancers as we get older, right? Well, because at some point, I mean, you get old enough, your body's going to make a mistake, and that's what it is. It's just that risk factor. Your body makes a mistake in that cell division. Family history. Genetics, as we talked about, for uterine cancer, there's about 15 to 20% of ovarian cancers that are associated with hereditary reasons. And there's usually sort of multiple cancers that are, that the patterns that you'll see in a family, like there will be a lot of breast cancers and ovarian cancers, or there will be a lot of gastrointestinal cancers, colon cancers, uterine cancers, and ovarian cancers. Okay, so those kind of, there's a lot of sort of thyroid and prostate cancers and melanomas. I mean, those are all, so if you sort of know, are aware of your family history, and then it should be emphasized to your doctors, okay? Especially if there's a lot of sort of cancers, to just see, is there a pattern, amongst these cancers. Infertility is another risk factor. We don't quite understand that one. It used to be that we think that infertility medications increase the risk of ovarian cancer, and that's been proven to be incorrect. It's actually something inherent in the patient who's gone through infertility aspect that increases their risk of ovarian cancer, and we don't quite fully understand that. And then delayed childbearing, again, one of the concepts about ovarian cancer is that the more ovulation cycles that we have, so the more actually regular menstrual cycles we ovulate every month, then the more at risk we are, because during ovulation the cells are changing. So again, there's more likelihood that the cells can make a mistake, okay, during that time. So as a result, birth control pills, for example, and I'll talk about that next, decrease the risk of ovarian cancer because they inhibit ovulation. Birth control pills overtake our body's mechanism, so we don't ovulate, and so they decrease. As a result, they decrease risk of ovarian cancer. So screening and prevention, there isn't any good screening available, as I was telling you. The standard guidelines do not, say that we should be getting this test every year, or this test, every couple of years. So, and then oral contraceptives are actually a good mechanism. So actually, sometimes in my patients who are younger and have higher risk of ovarian cancer by by an inherited mutation, even if they're at risk for breast cancer, I might actually put them on oral contraceptives because oral contraceptives will decrease their risk of ovarian cancer, and if they do develop breast cancer, well, at least it can be picked up early, again, because oral contraceptives do slightly increase their risk of breast cancer. And again, prophylactic surgery in those patients who are at significant risk. So again, in some of these patients who have the inherited mutation, as I said, that incidence of 1.3 to 1.7%, some of these patients can have as high of an incidence, a risk of 50%. Okay. So transvaginal ultrasound, which is very often used to evaluate pelvic symptoms, it can be useful as part of an ovarian cancer risk reduction program, but unfortunately, it can send a lot of red flags. You know, it may be very frequently abnormal because every month as we go through the cycles, we form cysts, okay, and some of the cysts can persist, and that can throw a big red flag with that, for no reason, basically. So it's been shown that if we sort of just use ultrasounds as a guidance, we will end up doing several unnecessary surgeries to pick up one ovarian cancer, which doesn't go well for that. So it's not recommended as a screening tool, okay? So another thing that I always sort of get asked about, especially my patients who get diagnosed with ovarian cancer, they're like, well, why didn't my doctor check my CA-125? Because now they know about this CA-125. Well, CA-125 is a tumor marker. It's a blood test that's done that can be elevated in majority of the ovarian cancers, okay? We don't use it as a screening tool because it's an inflammatory marker. It's not specific to ovarian cancer. So it can be elevated, first of all, in 1% of healthy women for no reason whatsoever. They can just have an elevated CA-125, okay? Or it can be elevated during your menstrual cycle. So if you got the blood test done during your menses, then it can be elevated. If you happen to have a GI bug that day, it can be elevated. If you have fibroids, the CA-125 can be elevated. So there are any kind of things that could be sort of causing inflammation can raise the CA-125. So first of all, we don't just use one number, and then second, we don't use it as a screening tool because there's so many other reasons.
Dr. Broad, PSA for men is not any better than CA.
No, it's not.
But for some reason, the insurance company agreed to pay for PSA and CA. And it's the same problems, actually. I'm an advocate of the CA-125. I understand the issue.
Mm-hmm.
But we need to clarify it.
I think we just need more.
We need to have a test
I think
equivalent to the PSA test.
I agree. The problem is, again, it's the number of patients, right? So 160,000 prostate cancer patients versus 22,000 ovarian cancer patients, okay? And that's the whole point, that how many people are you going to test, and send red flags on, versus, that is the whole reason for the screening test. Well, so that's what's being tested at MD Anderson, where that should we be trending CA-125 after a certain age, and not just go by one level, but like every year if we do a CA-125 and the trend is going up, those are the patients we need to, examine and sort of look into further. And that is definitely being studied, so. The treatment for ovarian cancer is radical surgery. I did 2 yesterday, spent about 3.5 hours each on each patient, where the goal of the surgery is to remove all visible. I showed you those nodules, like how friable the cancer is. Remove all visible lesions like that in the abdomen, and sometimes there could be thousands of those lesions, and we know that we can't actually remove all of them, but sometimes we can, and we are successful in removing all of them. And so we render the patient with microscopic disease, okay, meaning that they still will probably have cancer cells, but we just can't see them, okay? And that's been shown to have the optimal outcome. That shows that we give that patient the best chance for survival and prognostic chances. Majority of the ovarian cancer patients will end up getting chemotherapy subsequently after surgery. On occasion, they end up getting chemotherapy before surgery if we think that we cannot with surgery, we cannot actually render them optimal, meaning I can't possibly remove all visible cancer. Or in order to do that, I have to take out multiple organs, and the patient's body just can't handle it. That's when we choose to give them chemotherapy first to shrink the cancer, and then take them back for debulking surgery. Methods for chemotherapy, some of the latest stuff is what's called dose-dense chemotherapy, where we used to give chemotherapy every 3 weeks, and now it's been shown that it works a little bit different if we give it every week, and it may be more effective. So those kind of things are being studied. And then something called intraperitoneal chemotherapy, where we're giving the chemotherapy directly in the abdomen. We put a port inside and infuse the chemotherapy directly to bathe that tissue where the cancer was, and that has been shown to have higher survival rate as well. One more plug for GYN oncologists, that surgery should be done by a GYN oncologist, because 97% of the time that patient is going to get the correct surgery, versus if an OBGYN, a general OBGYN, does the surgery 50% of the time, and a general surgeon does the surgery, it's about 35% of the times, okay? My family lives down in Georgia, and when I was trying to decide where to move, about 9 years ago when I was looking for a job, my brother and sister-in-law are physicians as well, and they live in a smaller area in Georgia, and over there these surgeries are being done by general GYNs along with general surgeons, so together they're doing the surgeries. They didn't want a GYN oncologist to move there because they don't want me to take their business away, but yeah, I mean, so it's not an unheard of concept. It's happening so much. Not only on the coastal America, but middle of the country, it's happening a lot because there's only about 1,200 of us in the country, GYN oncologists, so, and most of us are on the coasts. Surgical new directions, as we talked about, neoadjuvant chemotherapy, so that concept is relatively new. There used to be, I remember I started off the talk where there are big centers where the academic GYN oncologists are doing those big surgeries. They don't believe in this neoadjuvant, which is chemotherapy before the debulking surgery concept. They think that every ovarian cancer patient needs to go to the operating room, and they need to, even if it's like taking out multiple organs at that first surgery, and it's weeks on in the ICU and all of that, they need to go through that, okay, to get the best survival chance. Many of us have walked away from that. Europe has completely walked away from that. The concept started in European trials, and it's been shown in every other organ system. It's been shown again and again in breast cancer, where they used to do like huge chest wall resections for breast cancer, and like now they do 2 millimeter margin resections for the same cancer. So it's been shown that bigger surgery is not necessarily the answer. It is many a times when we can completely remove it without causing a lot of quality of life issues, but not in a scenario where when we're really affecting the patient's subsequent recovery. We also do what's called secondary or tertiary debulking, and again, that is if a patient has a recurrence of ovarian cancer and it's isolated recurrences, then those patients that is amenable to surgery. Why surgery is important is because the larger tissue that we take out that's cancerous and we're leaving the little cells, those remaining cells are more sensitive to chemotherapy, okay? If we're leaving large bulky tumor behind, the chemotherapy doesn't penetrate that cancer very well, so it's not as effective. So that's why the people who don't believe in the neoadjuvant chemotherapy, that's their concept, that, well, you're not going to be as effective. Final remarks? Okay, so I know that we have made an impact, okay? GYN oncology became a specialty in like 1972. So we're only about 35 years old, 45 years old. And but in this time period, we made a big impact. This is the first time, especially in the last, even just in my training time, I've seen so many shifts in treatments and survivals as a result. But we're still in just baby steps. And the reason for that, if you sort of just compare with breast cancer, when you have 250,000 patients that you can get data from versus 120,000, and out of that, like the big one is the ovarian cancer, only 20,000 patients. We can't collect the data as fast, So I think, but still we have exciting times that are still ahead of us, and hopefully a lot more to go. Thank you. Welcome. I think it can be made available. Melanie asked that question. I don't know where she went. I think it can be made available. Yes.
What's the recovery time for like if you take your uterus out?
So if we're doing a laparoscopic surgery, patients are walking the same day from the surgery. They can even go up and down the stairs the same day from the surgery. Within 2 weeks, you feel pretty good. Okay, the internal healing still takes about 6 weeks. All the tissue, because it's the same surgery that we used to do big open. It's just that you have tiny incisions on the outside, so you heal quickly from here, but inside is still going to take that 6 weeks. Yeah.
What are the guidelines for treating women who test positive for the BRCA gene?
The question was, what are the guidelines for testing for BRCA genes and things? So there are a whole slew of criteria, based on your risk factors. It's mostly family history. Okay, the problem with that is that you could be that first person who is starting that family history, so you won't get diagnosed with that gene because you don't meet the criteria for that mutation testing. But then the subsequent generation, will meet the criteria. Any ovarian cancer patient, as soon as you get the diagnosis of ovarian cancer, actually meets the criteria for genetic mutation testing. The problem is most of the patients actually have breast cancer first, and then they don't necessarily get tested, unless they actually have those other risk factors. So, yeah. Hold on. I'll start with you first. Okay. Uh-huh. Right. Oh, yeah, absolutely. So the question was that if you've had a hysterectomy and you've been tested for the mutation and you come out negative, your risks are very low. Yes, absolutely. Yep. Your question? So there are two schools of thought on that. Some believe that the HPV stays in, once you get it, it stays in your body forever, and the times that we're testing and we're not detecting it is because it's just at an undetectable level because it's a virus, so if it's a very low count, then it's not detectable. But some believe that your body does fight off the virus, like we fight off other viruses, and your immune system just fights it off. So yes, but yeah, and you can get it again. Yes, it's not, you don't develop antibodies against it. Sometimes your body gets, your immune system becomes maybe stronger at fighting it, but you don't necessarily develop antibodies against it. So if your risk factors change, you can contract it again. Yep. Question? At risk for cancer? Yes. So the question was, are women with endometriosis at more risk for cancer? Yes, they are actually. It's been shown that patients who have endometriosis actually can be at risk for certain types of cancers, including ovarian and uterine cancers. And the certain types of ovarian cancers are something called endometrioid cancer, which actually has better prognosis than the run-of-the-mill ovarian cancers, which are serous cancers. But there's another one that they can be associated with, and that's called clear cell carcinoma, and that's a very aggressive cancer. So it can be a spectrum of any of those. But yes, endometriosis can increase your risk. That concept has not been studied, or at least I'm unaware of the data, that if endometriosis has been treated, does that decrease your risk of cancer? We don't know that. I don't know that. Yeah. Any other questions? Yes.
General one, with the symptoms of ovarian cancer being so non-specific, do you have any recommendations for when someone would think to, or should think to, like how bad do the symptoms have to be to?
It has to be something that's norm for you. Okay, so you really have to be sort of, that's the whole reason when we say you need to do your own breast exams, okay, and then you pick up the abnormality. Majority of the breast cancers still are picked up by self-exams, right? So it's basically knowing your body, okay? Those 2 days out of each month, I get bloated. I know, okay, I'm gonna get my menses and all of that. That's different versus, I can't remember the last couple of months. Maybe I had a day or two where I felt good, but most of the time I didn't feel good, okay? And that's a red flag, yeah. So it's mostly like that, yeah. And I mean, that's what they looked for. They literally, the way this research was done, it was actually done by my fellowships director at University of Washington. And you can actually look it up because it was on the front page of New York Times. It's Barbara Goff and ovarian cancer signs and symptoms. Basically what they did is they actually went to like a general clinic essentially and asked women to fill out surveys, okay? And then sort of did the follow through and figured out, how many of those actually ended up getting diagnosed with ovarian cancer. And essentially it was that's how they picked up that, most women, even early stage cancers, did have symptoms. Yeah, didn't put it all together. Well, because if you think about it, you're going to go to your primary care doctor and you're going to tell them about bloating. They're going to first send you to a gastroenterologist. Okay, so it's okay to go through that pattern because yes, I mean the incidence of ovarian cancer is very low, so majority of times it's going to be other issues, but it shouldn't take months. Okay, it just basically, when you start having those symptoms, keep following through on it, and you should be able to get to the correct, answer sooner than, several months. Okay, and that can make a difference between survival.